Okay, good afternoon, ladies and gentlemen. We are here at Bright Blue. We're an independent think tank for liberal conservatism. Our mission is to defend and improve liberal society. And this is our Ludgate Lecture, which we try to have monthly with senior decision makers and opinion formers. This month, we have Matthew Taylor, who is the Chief Executive of the NHS Confederation, previously Chief Executive of the Royal Society of Arts, and former Director of Policy in number 10 Downing Street in the New Labour government. And the lecture today is, has the NHS become unmanageable? And this month we saw the 75th anniversary of the NHS. Obviously, the British public feel very proud of the institution, but in terms of its outcomes, particularly in recent years and relative to other international health systems, there's questions that need to be answered. And obviously, at the moment, we've had a long period of strikes, particularly from junior doctors, and now a two-day strike starting today from consultant doctors, which a lot of commentators say will have a profound impact because there will be no elective procedures. And more broadly, the model of increased taxpayer support, real terms increases that we've seen over a number of years is being called into question as a result of outcomes not improving. So Matthew is going to tell us a little bit about what's going on. Can Rishi Sunak achieve his promise of reducing the waiting times? And do we need to think big about how to reform the NHS so that we have a different model which is more comparable to, for example, our European neighbours? If you're tweeting, please use the hashtag Ludgate Lecture, and you will see under your YouTube video a Slido link where you can ask questions to the speaker. So please use the code Ludgate Lecture, and I will field those questions and give them to Matthew. But before you get to hear the answers to your questions, Matthew is going to give us a speech on, has the NHS become unmanageable? So over to you, Matthew.
Well, thanks, Ryan, and it's great to be here. I've done work with Bright Blue over many, many years in different capacities, and it's always enjoyable to be with you. I should say something about what the NHS Confed is, just to start off. So the Confederation represents all parts of the health service in England, Wales and Northern Ireland. So not just trusts, but also integrated care systems and primary care as well. So in answer to your question, I think the NHS is in a very difficult, a very challenging situation at the moment. But I also think that we know what we need to do to get things back on an even keel. And indeed, we know what we need to do in order to take full advantage of the opportunities that are going to coming down the track to improve the nation's health. So I think a good place to start is with how the public feel about the NHS. And the public feel three things which kind of not necessarily, you wouldn't necessarily assume would go together, but they do go together at the moment. So the public has lower confidence in the health service than they've had for a long time. The public is pessimistic about access in particular to the health service. However, the public continues to rate the care that it receives very highly. I was just looking at some data this morning. Over 80% of people say that they are satisfied or very satisfied with the care they get when they get access to primary care. But obviously the issue is getting that access to primary care. So people rate the care they get highly, and the quality of care seems to be pretty good. And then thirdly, the public continues to be very committed to the founding principles of the NHS, which is interesting. We know that there are other elements of society where people have a commitment to equality or social justice or fairness, but in a sense that they're not committed to the means of achieving that. So if you take one area, if we were to ask people, do you think that inherited wealth should be a major determinant of people's life chances? People would say no, probably. If you then said, would you think we should have higher inheritance tax? People would also say no. So there are many areas where our commitment to fairness is belied by our view of the particular policy interventions, but the NHS is an exception to that. We believe in fairness when it comes to health, and we support the primary mechanism to deliver that, which is a health service based upon those founding principles. So that's kind of where we are in terms of where the public is. But the second thing I want to make before getting into the kind of core of my argument is that an important part of the context for our conversation is the change that is taking place in relation to the opportunities that exist for people to invest in and try to improve their health. So partly this is simply a response to the challenges the health service is facing, particularly those elective waiting lists. So we have seen a growing use of the private sector, particularly in payments for particular procedures. But beyond that, and possibly more fundamentally, we are seeing growing opportunities for self-diagnosis, for self-monitoring, for access to advice. So I don't know how many of you go on the London Underground, but you'll know that if you do go on the London Underground, an increasingly high proportion of advertisements on London Underground are for you to send in various samples in order to be diagnosed by independent healthcare data companies. There's obviously growing opportunities to monitor your health through wearables of various kinds and more online services available. So if we're committed to that notion of equity, we need to recognize that unless the health service is able to improve and personalize the care that it gets, the danger is that more and more opportunities will be available to people who are better off to take advantage of these new services being provided by the commercial sector. So this is the kind of burning platform. There are a number of burning platforms, I guess, in the NHS, but this is one of the burning platforms. We have to improve what we do. We have to personalize what we do. We have to get better at prevention, or else the public will vote with their feet. And as Richard Titmuss famously said all those years ago, the problem with a service for poor people is that it soon becomes a poor service. And so if the NHS were to be in a situation where more and more of us get our health needs met outside the health service, then the constituency of support for it would decline. So that's the context, in the broader context in which I think we're operating. So what I'm now going to focus on in the next kind of 10 or so minutes is what do we need to do? And I'm going to talk about five things here, five things that I think we need to do if we are to put the health service back on track. But in particular, the things that we need to do if we are going to take advantage of the enormous possibilities that biomedicine and technology are going to offer us in the years ahead. So the first, and given my political background, given that I represent the NHS, you might not be surprised to hear me say this, but the first is investment. I want to get that out of the way early. Now, the important thing I think to recognize about investment is that what drives demand in the health service is well known. It is true in all developed countries. It is a combination of growing demand, particularly related to population aging, and rising expectations. Rising expectations in the sense that we talk a lot about cancer outcomes, and the situation in relation to cancer outcomes in the NHS is that we are pretty good when people have got a diagnosis, but we're not diagnosing people as early as other countries. That's the big difference, is that late diagnosis, although we are getting a bit better at that despite all the other challenges. But if you think of cancer, I guess for my grandfather's generation, if they had a cancer diagnosis, it was pretty much, go home and get your affairs in order. And now that has fundamentally changed. A few years ago, we passed the point where more than 50% of people with a cancer diagnosis live more than 5 years. Now, that's great. But of course, that's a lot of people having very often pretty expensive forms of treatment to extend their life. It is fantastic that there appears now to be breakthroughs in relation to dementia. But those will also be extremely expensive. And it looks as though at the moment, they won't stop dementia. They will slow it down. They'll just mean a lot more people probably wanting to have and deserving to have expensive forms of treatment. So growing demand and growing expectations is what drives the cost of health, plus, of course, the fact that health is a labour-intensive area of activity. And as you know, it is a tendency for labour-intensive service areas of the economy for their relative costs to go up in comparison to other areas of the economy like manufacturing, which are not so labour-intensive. So all of those things drive costs. And we kind of know that, and health economists, generally speaking, would say that you need probably growth, real growth in health service spending of around 3 to 4% to sustain performance in relation to those factors. What we had in the UK, and I'm not making this point politically, because the point about austerity is not really its impact. I think we can agree on that. The question is how justified it was, and that's a subject for an economics talk, not for a health talk. But I think we can agree that the impact of austerity was pretty substantial on the health service. As we went into austerity, we were meeting all our targets, and the health service was seen as one of the most successful in the world. By the time COVID arrives, we have 100,000 vacancies. Our capital stock, our estate, our equipment has fallen far behind the rest of the world. Estimated by the Health Foundation that austerity left us 30 or 40 billion pounds behind where we were with comparative countries in comparison to where we were at the beginning of austerity. That meant that COVID hit us particularly hard. And it's not just that, it's also certain policies that we had. So we've always had a policy, and this was a Blair policy as well, to try to minimize the number of hospital beds that we have to get people out of hospital as quickly as possible. That's a good policy because hospital's not a great place to be unless you really need to be there. But it meant that when COVID hit, we had very little slack. It was we more than almost any other country had to stop other forms of activity in order to deal with the demands of the various COVID waves. So the first thing we are going to have to do is invest more and more consistently. It's great that we now have a long-term workforce plan, and kudos to Jeremy Hunt and to Steve Barclay, and indeed to the Prime Minister for getting that out. But as that plan recognises, it will take several years to address the over 100,000 vacancies we have in the health service. And we also urgently need capital investment, and that will be the main focus of our lobbying up to the autumn statement. The failure of capital investment is, yes, it expresses itself in crumbling hospitals and poor equipment and the poor quality of primary care facilities, but it also is a massive barrier to productivity improvement and innovation. But I just want to make two final points about investment. One is we need to, I think, recognize that investment in the health service is not just pouring money into a black hole, that there are significant economic spillover effects from health investment. We've published research showing that there is a kind of £4 to £1 return in terms of economic benefits of health investment. And indeed, we're publishing other research in the next few days that will show that that return is even higher when the money is invested in primary and community services. So there are big economic benefits to be gained, or conversely, when your health and care system is not working, it also has major economic downsides. And one of those, of course, we see in the high levels of economic inactivity resulting from health and care issues. But the final thing I want to say about investment is I do also think that we need to aspire to the graph, the demand graph, flattening out. And I think this is a debate that is really worth having. At what point, 10, 15 years ahead, can we see, I think health service spending is always probably going to grow because people want to spend a growing proportion of their income on health when they become better off, whether that's individually or socially, collectively. But I think we can flatten out, and that could be the consequence of the diagnostic revolution, which is now unfolding, which will enable us to be able to identify more and more illnesses at an earlier stage and be able to address them at an earlier stage and at a cheaper stage. So that's the first point. We need to get real about investment. Secondly, we need to recognize that what we need to improve our health is a health strategy, not just NHS policies. So as you all know, historically, whether it's 19th century shifts in urban sanitation or more recently the smoking ban, that major changes to the nation's health have been the consequences of things that have taken place outside the health service. It's estimated that only around 15% of our health outcomes are determined by the treatment that we get through the health service. So we need a broader strategy for health, not just one for the NHS. And that also, of course, needs to encompass social care. One of the big challenges for the health service is, of course, as you know, people get stuck in hospital who don't need to be in hospital. And it's estimated that about half of the reason for that, half the reason that we have so many people in hospital who don't need to be in hospital, it's not good for them, it's not good for the hospitals, it's not good for the budget, is that there is inadequate social care available. And there are even more vacancies, as we know, in social care than there are in health. But also we need to take more seriously the housing consequences of other policy areas, whether it's housing, education, employment. I spoke to a GP in Manchester a couple of weeks ago. She told me, this is Rushcliffe, a kind of poor part of Manchester. She told me that 1 in 4 of her patients, their real problem is housing, not health. So we need to think about the consequences of policies in other areas, their knock-on effects on the health service. Now, I'm going to go to a third point, but before I do that, I just want to say something about the nature of Whitehall, because this is it might seem like an abstruse point, but it is relevant to the challenges we have in the health service. So I've said we need joining up on health. But the next point I'm going to make is we also need to devolve much more in health. We need to invert the pyramid of control in health. And I'll explain that in a minute. But those two things, a wider policy on health and a more devolved approach to health, the problem is that the nature of Whitehall mitigates against both of those things. So the character of government in England is this. It is highly centralized when it comes to geography, that is to say, high levels of control in the centre, much less devolved than other public service systems. But on the other hand, Whitehall itself is actually quite devolved. That is to say, within Whitehall, individual departments have quite a lot of power, and it's quite difficult to get working to take place across departments. So these two characteristics of our system, the devolved nature of the centre, but the centralized nature of the geographical distribution of power, both those, I think, things are unhelpful to the health service. So that takes me on to the third point, which is the need to invert the pyramid. So I think just today, our sister stroke competitor organisation, NHS Providers, published a report saying that the experience of trust leaders is that regulation has grown. We know that our health service creaks under a huge number of targets and regulatory systems. Now, and this would be a subject for another lecture, Ryan, but I've done years and years of looking at what makes for effective change, effective systems, effective organizations. And one thing that I take from all of that analysis is that the most effective systems are those that combine and balance 3 types of drivers for change: top-down drivers for change, accountability and strategy; lateral drivers for change, which is kind of values, peer-to-peer learning, professionalism; and bottom-up drivers of change. That's responsiveness to patients, to citizens, and to communities. That's what makes the most dynamic systems, organizations, and policies. The health service is simply far too driven by top-down pressures, and it squeezes out the scope for lateral learning and creativity and innovation, and for responsiveness and engagement of patients and communities and the public. A particular element of that centralization, which robs us of a kind of capacity for dynamism and responsiveness, is also high levels of political interference and short-termism. So the contribution that the major health think tanks, the Health Foundation, Nuffield, King's Fund, made to the 75th birthday was to publish something bemoaning the inherent short-termism of health leadership. A recent book by Isabel Hardman on the history of the health service, which I can recommend, it comes to the pretty clear conclusion that one of the biggest problems the health service has faced has been political interference, constant reorganization, constant emergence of new priorities of various forms of micromanagement. So we need to invert the pyramid. You know, I was talking to someone in France the other day about the health service, and the French health service, like every health service in the world, is under a lot of pressure because of those issues of demand that I talked about earlier on. But the point is that when something goes wrong with the health service in France, people don't blame President Macron. You know, they think it's a consequence of their local health system or their local health professionals and something which they can address and engage. Not everything gets bounced up into becoming a political football. Now, I'm trying to connect all my points, you'll notice here. So I've talked about this kind of need to invert the pyramid. By the way, what I mean by inverting the pyramid is what we need is a system where accountability is not something you owe upwards to the next tier above you, but something you owe downwards to the tiers below you and ultimately to patients themselves. Now, one of the problems with political interference and short-termism is it makes it very difficult to do the fourth thing that we need to do. And the fourth thing we need to do is we need to shift investment upstream. Now, you know, we've been talking about this for a long time. We absolutely know that we would get more bang for our buck. We would satisfy patients more. We would prevent ill health more if we could take more of the money we put in the health service and proportionately invest less in the acute sector and more in primary prevention and community-based services. Now, everybody wants to do this, but we have failed catastrophically to deliver it. And so, for example, we have many, many more. Since the NHS published a long-term plan which committed to this upward or sometimes called leftward shift of resources, since then, the number of GPs, full-time equivalent GPs, has fallen. The number of hospital consultants has substantially risen. So we actually find this incredibly difficult to do. Now, there's lots of potential. I go out into the health service 2 or 3 times a week, talk to people. I see the best practice in primary care, which is around primary care, really using data to understand the health of their population and to try to be more proactive in reaching out to those people with the highest needs. I see really good examples in the community sector and sometimes led by the acute sector of virtual care, people getting hospital level care or other forms of monitoring and support in their home using technology, something which is effective and which patients like. But there's lots of scope to try to shift that. We're doing a lot of work at the Confed about how you would shift resource allocation, but it's constantly undermined by the central focus on the acute sector and what is, of course, the Prime Minister. The Prime Minister is the most important politician in the country. What he says is what matters. What is his number one priority for the health service? Reducing elective waiting lists. So again, not surprisingly, that's where the resource goes. That's where the emphasis goes. So that's the fourth thing we need to do to try to accomplish this shift of resources upstream, because it's better for patients and it's more efficient use of our resources. But part of doing that takes me to my fifth and final point, Ryan, which is that we also need a new social contract for health. So health is based upon a kind of classic social contract idea, and that is that you will get the healthcare that you need, you will get it on the basis of need, in return for funding that health service through your taxes. Now that's fine, but it's a kind of heritage, it's a kind of legacy contract. It's not one that we today create or recreate, and also it requires nothing more of us than for us to pay our taxes. But actually, the shifts that we need in the health service would benefit enormously from patients and carers themselves being very active in that. So I'll give you a couple of examples. Patient-initiated follow-up. So this is a way of improving throughput, reducing unnecessary interventions by simply moving away from a model where you have an operation, you are automatically called back for an outpatient appointment after 6 months, and instead saying, no, you, the patient, decide. You know, we'll contact you, if you don't think you need an outpatient appointment, you won't have one. We'll rely on you to do that. Or take the notion of anticipatory care. So I spoke to a health service leader the other day who said, if there was one thing I wish I could do, I wish I could stop us bringing into hospital people in the last year of their lives who are going to benefit almost nothing, they'll hardly get any benefit at all from coming into hospital. It'll be an unpleasant experience. It'll do very little for them, but it will be incredibly expensive and probably not great actually in terms of their dignity and their well-being. Anticipatory care is a model in which we work with patients and their carers towards the end of life generally and say, well, what care do you want? Let's agree what you're going to get. And let's agree, for example, that unless there are overwhelming reasons to do so, we are not going to be taking you to A&E again between now and the end of your life. Lots and lots of other examples. Virtual care, which requires people to be more active at home and their carers more active at home, to use technology. So we need, in many ways, to engage patients more as partners. And I think a new social contract is really about the health service giving more, but also expecting more back from people. And this involves a number of things, which I'll finish with. It means, first of all, that our narrative, our national narrative, has to change. When politicians talk about health, and we'll get more of this as we build up to the general election, it's all about what we call in politics the retail offer, what we have to give to patients. We need to shift that narrative in a way slightly reminiscent of the kind of big society discourse of David Cameron, and talk more about how the future of the health service has to be one, as I say, in which we try to give people better. We try to personalize care, to empower people with their care, but also how do we empower people themselves to take more responsibility? You know, by the way, there are fantastic examples of this. I'll come to one or two in a minute. So that the narrative needs to change. Secondly, in the way we design services, we need to involve patients and carers much more in how we design services so that they are designed in ways which give patients that sense of agency and partnership. And so, I'll give you one great example of that, which is work we've done in the area of diabetes. And I've seen this with my sister-in-law. She was told that she was at risk of developing type 2 diabetes. She'd been overweight for many, many years, but she was told this is it, now or never, really. She went on to a very, difficult, challenging diet, but, it was, I think, 12 weeks of eating virtually nothing but soup. At the end of that, she's a different person. She's healthier, she's happier, she started running. And critically, when I said to her at the end of that process, how would it be if the health service was to ask you to mentor 2 or 3 other people who were at the beginning of the journey that you've been on? She said, I'd love to do that. It would be great. I'm sure it would help me stay on the straight and narrow as well. Another example of this I saw was in Sussex, where they brought together all the patients on the musculoskeletal waiting list, brought them all together, had a day with them, a lot of time with clinicians, a lot of presentations, nice event. At the end of it, half of those patients chose to come off the waiting list and self-manage. So there are all sorts of benefits we can get from engaging patients more actively. So we have to do that in the design of services. And then finally, we need to do it in terms of the clinical engagement. And this is a big issue for primary care. We know that the vast majority of health service resources are dedicated to people who have multi-morbidity. They have a number of conditions, and their needs are very different from the kind of episodic needs, Ryan, that you and I might have, where most of the time we don't use the health service and then we, spot a mole we're worried about, or we get a virus we can't shake off and then we go to the health service. Our needs are episodic, but there is a group of people, a large group of people, a growing number of people because of the population aging, who have multi-morbidity, and they need a continuous relationship with the health and care system. And so what we need in primary care is to distinguish between those two sets of needs. And of course, it's not as simple as that. These groups overlap. But those people who have that multi-morbidity need a really strong relationship. They are the people who do need continuity of care. And they need people spending proper time with them, because this is about them managing their lives. It's not just about treating the particular symptoms that present on any particular day. So in conclusion, and I'll end with this, Ryan, what I would say is that in relation to those 5 points I've made about investment, about a health policy, not just an NHS policy, about inverting the pyramid and devolving, about a upward shift of resources, and about a new social contract, I would say there is a pretty high level of consensus amongst people in the health service, health experts. So politically, what does that mean? I will say these three things. Firstly, I think we need to avoid dead-end conversations about alternative funding. The reality is, and huge amounts of research, there's no evidence that having a different way of funding our health service would make much difference. But the one thing it would absolutely do is be a weapon of mass distraction. It would mean that for years and years, we were plunged into massive reorganization when we should be doing other things. So for me, that's a dead end and a distraction. Second, and by the way, if we had a social insurance system in this country, I would probably make the same argument if someone was saying, well, let's go to a universal tax-based system. It's not that I'm saying our system is particularly better than others. It's simply that our system is certainly no worse than others. There's no evidence that it would improve if it was funded differently, but it would be a hugely disruptive thing to do. Secondly, we need to accept the basic realities. That's particularly in relation to investment and population aging. We need to recognize that if you don't put enough money into the health service, what happens is that you get what we've got. And, you know, there was a time when we put more money into the health service and we hit all our targets and we were seen as the best health system in the world. Then we reduced the funding and now we're not meeting our targets and we're not performing so well. So we just have to accept those basic realities. Hopefully try not to politicize them, because these are internationally accepted truths. And then finally, in terms of, Bright Blue as an organization that seeks to influence the national discourse, we need from the center in particular, a more consistent, more strategic and more focused center. So I think a big issue for an incoming new government, or for this government if it's re-elected, is that in many ways Whitehall just doesn't work. And I think in the health service is one of those areas it doesn't work. And so part of the health challenge is also part of a broader challenge of how we move to a center of government which is more effective at enabling and empowering people to deliver the public services that we need. And with that, Ryan, I'll end.
Brilliant stuff. Thank you, Matthew. Typically and fantastically very thoughtful. I've got a few questions, but just to remind everybody who's watching from afar, wherever you might be, that you can ask questions through Slido, and the link is underneath your YouTube video, and you can use the code Ludgate Lecture. So my first question is on this kind of new social contract that you talked about, the fifth priority. And it reminded me a little bit of the kind of focus from New Labour on reforming the welfare system in the noughties, this sort of something for something culture, and applying that more broadly to the NHS. And I can see why that might be very appealing to people on the centre-right. I suppose two questions from that. Some people would say, does that kind of favour the sort of sharp-elbowed middle classes, who are always very proactive and know what to get from services which are quite complex and bureaucratic? So there is a danger. Is there a danger of that? And then the second question is, and I know you told me and others to not focus on alternative funding, but the sort of kind of logical extension of this is, the model that we have at the moment is a kind of insurance tax-based, needs-based model. Should we have more co-payments where you kind of move to a more consumption-based model where people do contribute more if they consume more from the health service? It's not just based on level of wealth and taxation. Is that not a logical extension of the something for something concept that you talk about?
Well, brilliant questions, Brian. So in relation to the first, it's a very good point. And I think the two answers to it. First, when I talk about a new social contract, that has to be part of an overall package that also recognizes those structural factors, those social determinants of health that I talked about before. I'm not wanting to move to a situation where we say, well, the only thing that really determines your health is your own individual agency and actions, because that simply isn't the case. So I think that it also has to happen in the context of the health service having the investment that it needs. And one of the reasons politicians won't talk about this notion of social contract is that they understandably say, well, if I said to the public, look, you need to kind of be more active yourself, they'll say, well, hold on, I can't see my GP. I've been waiting years for an operation. So it feels like an unrealistic conversation to have. It's why it is, I guess it's organizations like ours who can say that. Maybe it's too difficult for politicians. But if we were investing more, if we were improving access, if we were attending to those wider factors that shape health, then I think this should also be part of our conversation. The second point is, you're right. We need to make sure that when we seek to empower people, we recognize that for people who are further away from power, who have lower levels of trust, it's a challenge. But here, Ryan, we can learn a lot from the successes of COVID. You know, because of Downing Street parties and culture wars over lockdown, we no longer talk, do we, about, we used to talk, didn't we, very earnestly about how we learn the lessons from COVID. Well, I think we need to go back to that. One of the lessons we learned from COVID is the incredible level of responsibility people took. They didn't just change their lives. We all undertook diagnostic tests at home. We all became fascinated by the public health data. And the health service realized that in order to reach communities, particularly in terms of the vaccination program, it needed to work in different ways. So actually, one of the things that happened in the health service is we got a letter from Simon Stevens, who then ran NHS England. And that letter basically said, look, we're in a crisis. Do what you need to do. I'm not going to tell you what to do. You've just got to, I'll give you the money. We'll have some national systems, but you've got to do what you've got to do. And that led to working with local government, with the voluntary sector, taking vaccination centres out into communities using churches and other organisations. So yes, if we want to empower people, we need to recognise you have to put a lot more energy into empowering those people who have lower levels of trust, who are further away from power. In relation to your second point, look, I want to avoid an ideological, view about this. I do think that once you start, charging people for things, then, it will tend to drive greater inequality for the reason you articulated in the first half of your question, Ryan. But I also think the evidence suggests that such systems probably will cause more problems than they're worth. The administration that is involved in them, the fact that most people would be not part of them, like prescriptions, where the vast majority of prescriptions aren't paid for because they go to retired people or they go to people who are on benefits of various kinds. So when you look at these systems in depth, what you end up with is a relatively small number of people will pay it. Most people will resent it. And the administration that is involved in charging people and chasing it up isn't worth it. So I'm not ideologically opposed to co-payment. I just don't think it's much of a solution for us.
Great, thank you. Very interesting points. So the next thing that I wanted to talk about was the issue you had around, the priority that you had around thinking about the health system in much broader terms and devolving it. And I know in other work that you've done that you've been, convinced by this sort of idea that centralized systems don't work, where you can kind of pull one policy lever and expect everything to change. And you're obviously thinking that through in health as well. And I know you're not making a political point. You just want us to accept the reality that in the noughties there was more investment, and that's why the outcomes were better. And we had a system which internationally was seen as very, very good. So, just to understand that a bit more, from what you're saying, it seems to be that really the problems we're facing today is the lack of investment. That's the crux issue. But of course, what a lot of Tories said back in the kind of old New Labour days was that there was too much centralisation, there was too much top-down targets. And it's interesting what you say about there's been an increase in regulation since then. But, is there an argument to say actually those top-down targets, as well as the additional investment, were quite impactful in improving outcomes and making sure the system delivered? So are you kind of ruling out any top-down targets, or are you saying they just have to be very strategically focused?
Absolutely the latter. When I talk about that model of the most effective systems, I talk about top down and lateral and bottom up. Top down is really important, but it needs to be limited. You need to recognize that every new target you add diminishes the power of the existing set of targets. And, there are lots of great initiatives that the government pushes, but the problem is that it's much better at creating new initiatives than it is at killing off previous initiatives. And, when you're on the front line, you just see it's a kind of confusion, a plethora of these. So it's firstly, there are just, too many. And we worked on the Patricia Hewitt review, which argued for fewer national targets, for also particularly for fewer short-term funding pots. People in local government will recognise this problem, where you have to put a lot of work into getting the money, applying for the money comes, it's got all sorts of strings attached to it, and then after a year that stream is closed down, another stream is opened up. So all of that kind of stuff. But secondly, it's also about having intelligent targets. And that goes to my point about the leftward shift. Ultimately what we want is to improve health outcomes. And I think, one of the kind of truisms in the health service is that at the moment what we do is we fund institutions and we incentivize activity. What we actually need to do is to fund pathways and people and to incentivize outcomes. So what we need at the center is more intelligent, strategic, long-term strategic priorities that shift the health service in the direction we've got. What we instead have is a proliferation of targets, many of which are quite short-term, which have the overall effect of reinforcing the current distribution of investment.
Great. At the start, you talked about the danger of more affluent people moving out of the NHS and that then becoming a poorer service for poorer people and the dangers around that. Now, one thing that people on the centre-right say is actually we need more private sector involvement within the NHS. So you've talked about the danger of people leaving the NHS for the private sector. My understanding of the evidence, and correct me if I'm wrong, from Carol Proper at Imperial is that, better contestability in NHS services has led to improved efficiency and performance. So do you think there is a need to have increased private sector involvement in the NHS and above and beyond what exists already? And what specific services are we looking at? Or do you take the kind of left's view, which is this is just privatization, or the kind of more centre ground view, which is actually, as long as the asset stays with the state, then it isn't private sector involvement. It's just more, it isn't privatization. It's just more competition for the delivery of NHS services.
Well, Ryan, you know me well enough to know my answer to that. I mean, the NHS is a mixed market. So whether it's GPs, who are, of course, independent contractors, or whether it's our relationship with the pharmaceutical sector, a high proportion of our budget goes on drugs, which of course we buy from the private sector. The private sector builds our hospitals, provides our equipment. There are areas of provision, for example, in mental health, where we have long used the third and the independent sector as a provider. So it is a mixed market, and it should remain a mixed market. And my view about the use of the private sector is pragmatic. And I think that where it is clear that the private sector can bring additional capacity to the health service, then absolutely I welcome it. And obviously, private sector needs to be held to account. There are some dangers around skewing priorities. So there's some dangers about private sector's particularly good at certain procedures and certain things. So when the private sector comes in, it can mean that certain types of things get done very quickly, more quickly than other things, which are actually more important. But that's a design issue that you can deal with. But you've got to be a little bit careful. In some labour markets, it's pretty clear that where the independent sector grows, it simply cannibalizes the workforce of the public sector. So it's not really adding capacity. So I'm entirely pragmatic about this. Absolutely, we as a confederation work very cooperatively, enthusiastically with a range of private organisations that work with the health service. So I've got no ideological hang-ups, but we just need to be a little bit careful about when we bring the independent sector in, that we're not skewing our priorities, or as I say, ending up kind of cannibalising our own staff capacity.
So you talked about kind of shifting funding upstream or leftwards, and of course, a big issue is around obesity, particularly in this country relative to other countries. And of course, the big lesson from the pandemic, or one of the big lessons, was just how determinant obesity was in terms of likelihood of getting COVID and having poorer outcomes from that. Henry Dimbleby, who did the food strategy, has resigned. There's a lot of anxiousness, I think, in the public health world that the government is sort of backtracking on policies because there's a sort of fear that it's seen as nanny status. But presumably this is one of the areas which could make a hell of a lot of difference to kind kind of NHS outcomes if, frankly, there was less obesity. So just interested in your views in that area. What's the kind of, what's the big thing that government should really be doing, which could really help? And can we learn from overseas on that?
Yes, thanks, Ryan. And I think that it's not just the government, but the opposition is pulling back from that as well. They fear being seen as nanny state. And also with the cost of living crisis, anything which looks as though it might increase the price of food is not going to be popular. But you are absolutely right. I'm long in the tooth now, and I look back over my political career and think about what I've achieved and what I haven't achieved. And one of the things I am proud of is that I was in number 10 when the fight took place around the smoking ban. And it was one of those moments you get sometimes when you're working at the heart of government that you can be a bit entrepreneurial, because Tony was sitting on the fence, and there were some people, they're all men actually, who were hostile to the smoking ban. They thought it would go down very badly in working class constituencies. And there are other people, who mainly the women in the cabinet, who are very much in favour of it. And I was pleased to be kind of activist in that context, in helping the women to win that argument. And and I don't think anybody now would want to reverse the smoking ban, and it's already, we can see the benefits in public health. The sugar, the fizzy drink sugar tax has been a success. Very interestingly, not an unblemished success. It seems to have worked well with girls and reducing girls' consumption of sugary drinks, but not so much boys. But it hasn't reduced the profits of companies, and it certainly has reduced to a certain, for certain groups, it has reduced the amount of sugar that we. So there, I think, absolutely, we need to attend to how it is, both through tough regulation and through, behavioural insights, nudges. We can continuously, and also, by the way, redistribution. Because, there's no question now. I mean, there's become a mythology, which was that healthy food was cheaper than processed food. It absolutely isn't. It's 2 or 3 times more expensive than processed food, particularly if you include the cost of cooking it. So we've got to do all of those things. You've asked me for priorities. I would commit to abolishing smoking by 2035. And I would adopt the New Zealand system, which is that in New Zealand now, every year they raise the minimum smoking age by a year. So next year you have to be 19 to smoke, the next year you'll be 20. And so by the time we get to 2035, we won't have anybody, trying to do the maths here, we wouldn't have anybody under the age of 30 who was a smoker anyway. So I would do that. And I would also investigate other ways of effectively regulating food harms and promoting food goods. And I think, things like school meals are an important part of this. Banning fast food outlets from being too close to school gates. There's a whole number of things that you can do. None of them are serious intrusions into our civil liberties. But if they're well designed, as the smoking ban and as the sugary drink tax shows, they can have an effect. And generally speaking, after a few years, people would think you'd be crazy to want to reverse them.
So is your kind of argument here that we are where we are in terms of sugary food and drink 2 decades on from where we were with smoking, and we should be drawing those parallels?
Cigarettes are always bad. A cigarette is a bad thing. I'm not suggesting that the occasional ice cream, the occasional full English breakfast is a terrible thing. We've got to have enjoyment in our lives, and actually, enjoying your life, being optimistic is actually a health factor in itself. So no, I'm not. I don't think it's exactly the same as smoking. I think it's more like drinking, which is, what are the things that we can do to encourage people to do something in a healthy way rather than in an unhealthy way? I agree, for example, about minimum. I would have minimum alcohol pricing, and I would simply tax more effectively salt, fat, sugar in food, and encourage innovation in business. Businesses, you're sophisticated, Ryan. You and your audience know that there's this kind of ludicrous idea that says that regulation inhibits innovation in the corporate sector. It doesn't. What innovation does is it actually often drives innovation, because it forces businesses to think, oh, that's interesting. What can we do to create a product in this new regulatory or tax environment? So let's encourage the food industry to be more innovative in finding ways of producing food that is healthier and that people want to eat.
And then just a final one from me before I take questions from others is just generative AI. You know, sort of 7-8 months ago, nobody was talking about ChatGPT. There's now a lot of talk about it. Just sort of quickly, if you can,
yes.
How do you think it may change the health system in the short term, in the next 3 or 4 years, for example?
So I think that we will see certain tasks and certain interactions with the health service being more automated. And I think it'll be particularly the diagnostic end of things and the episodic end of things. So I think that we will see AI being used more to tell us whether or not we have got a condition, whether it's looking at scans or analyzing blood tests or whatever. I also think we'll see AI more in relation to enabling us, when we've got a set of symptoms, to be able to consult a pretty sophisticated system that will tell us in probability terms whether or not we ought to seek more help. And I think thirdly, obviously AI is also going to help us in terms of biomedicine, in terms of the development of new medicines. And that's possibly the most exciting thing of all, is the acceleration of innovation when it comes to medicine. But never forget that the biggest group, the biggest part of the cost of our health and care system is older people with multimorbidity. And those people are still going to need high levels of human contact, human support, human care. So the biggest demand on the health service is a group of people for whom AI is going to be much less significant.
Very interesting. Okay, I've got questions from people watching. So someone who's anonymous has said, has Brexit and the subsequent loss of ready access to EU health professionals noticeably affected the NHS? I'll take 3 if that's all right. And then the second question is from Joanna, who says, what do you think the NHS model will look like in 10 years' time? You've sort of answered that a bit in your lecture, but maybe if there's one thing that you think would be profoundly different then in a decade's time to today, that would probably be a good way of answering it. And then a third question from Joe, which is, should we not accept that demand for health services will always outstrip supply, and have a national conversation about how we limit health service provision?
My goodness, what brilliant questions. And we've only got 6 minutes left, so I'll try to answer them really quickly. The answer to the first is yes. But of course, the irony of Brexit is that what it's actually done is mean we have fewer Eastern European people coming here, but that's meant we've had to rely more on bringing people in from Asia and Africa. So that's been the kind of net effect. As we know, Brexit hasn't reduced immigration, it's just changed where immigrants come from. But certainly Brexit has had an impact, and particularly also on the care, and probably even more on the care sector. But of course, when you've got 160,000 vacancies in care, it has an immediate knock-on effect on health. So there's a direct and an indirect effect. In relation to this, what will be different in 10 years? So let me make 3 bets. First of all, I think we will recognise that health policy is not just about the NHS. We will realise that just talking about the NHS is talking about the very end, and that the NHS is always going to hamster wheel unless we're better at improving and supporting public health. That's the first thing. Secondly, I hope we'll have a system that's more devolved, and that we see more seamless working between the health service, local government, the voluntary sector. It will feel like we have a more integrated approach to health and care needs. And then thirdly, at the individual level, I think in 10 years' time, young people will no longer think, as we have thought since the dawn of time, that healthcare is something you seek when you have symptoms. I think that increasingly they'll see healthcare as something which you mobilize because your wearable, your annual blood test or whatever indicates to you that there might be a problem even before you've got a symptom.
Very interesting. Okay, I'm going to take the final round because you've been very pithy in your responses, which is great. So we have from an anonymous person, with the recent growth of private health insurance, is the UK sleepwalking into a 2-tier health system? And another anonymous person says, can public service mutuals be expanded in healthcare to make the NHS more efficient? And then finally, from Kane Hunter, would the NHS become more manageable if we adopted a mixed healthcare system based on collaboration between the NHS and private healthcare settings?
Right. So I realised, by the way, I didn't answer the third of the questions, the previous set of questions, and the answer is, in effect, we do ration healthcare, and we ration it in the sense that we don't provide everything that everybody might need, things like cosmetic surgery or whatever. You can see in America what happens if you have a health system that gives people whatever they kind of demand, but also we ration it sadly by people having to wait. And I agree with you. That's part of the idea of the social contract, that we need a better conversation with the public that kind of says, look, if we are going to be able to give you more, we're going to need to be able to call on you to be more active yourself and participants in your health. So that's the answer to that question. So Ryan, just briefly, do each question. I'll give each question 45 seconds. Remind me of them in turn.
Okay, yes. So the last one was from Kane Hunter, which is, would the NHS become more manageable if we adopted a mixed healthcare system based on collaboration between the NHS and private healthcare settings?
Look, I think I've answered that. I'm not opposed to that. I do think the British public want a health service which is where care is based upon need rather than resources. So I want to hold on to that principle, but I'm happy to see as much engagement with the private sector as benefits us. And you know, as Blairite and as also the person who produced a report on public-private partnerships many years ago at IPPR that said there was no ideological reason not to use the private sector. So I've got no problem about that. The point about mutuals, I'll go out on a limb here. I'm going out well beyond the NHS Confederation's actual policy. There are community interest companies. Many community services are run by community interest companies. We work very closely with the voluntary sector. I actually think there's something quite interesting about the health service moving to a model that starts to feel a bit more mutual, so that the health service no longer feels so much as the tentacles of a national system, but more a kind of locally owned a service. I think that goes with this kind of more active model that I've described. And there's just one question I've not covered.
Yeah. Private health insurance. Are we sleepwalking into a two-tier system because it's been increasing the take-up?
Yes, in the sense that more people now, because of the length of the elective waiting list, it's not so much that people are paying more for private insurance, they're paying more for individual private procedures. And that is a problem, and it is increasing inequity. But it's important to recognize two things. First of all, other countries that have encouraged people to use the private sector have often ended up, in Australia, for example, they had a tax incentive to opt out of the public healthcare system. People adopted it. Then when times got tough, when the economy stopped growing at such a rate, a lot of people wanted to come back into the health system, because in the end, you know, you have to pay for it, whether you pay for it for your taxes or you pay for it through your pocket. But also, to end with a consistent theme, Ryan, that I've had, private healthcare might be pretty good at this kind of episodic stuff. It is, as we know from social care, much, much less good when it comes to that group of people who are the major source of demand for the health service. Older people with multi-morbidity, very, very difficult to insure for that. That's not an attractive group to the private sector. So although we see bits of the NHS being, you know, there's a danger at the edges, as I described at the very beginning of my talk, of people using private services because they don't feel the health service can meet their needs. The really big core work that the health service does is not going to be, I don't think, taken over by the private sector anytime soon.
Great stuff. I think one thing that really came through here was, you know, if we're going to do a lot of the fantastic things that you've articulated, whether it's mutualization, devolution, then yes, there's sort of a kind of devolution of powers and and funding, but there also needs to be a kind of devolution of responsibility. And it struck me in your lecture when you talked about, you know, if things go wrong in the health service in France, they don't blame Emmanuel Macron, they blame the local kind of health service and the management there. And of course, we've got to move away from just blaming Jeremy Hunt for the woes of the NHS. And if we don't do that, and it's overly politicized, which I think the NHS is, then it's understandable the incentives are for politicians to sort of grab it and try and control it. And, you know, all the changes that you've been talking about within the NHS and the broader health space. It's also about changing the political system in a way, and the incentives that politicians have, so that we can see the reforms that you've been articulating. So thank you very much for joining us.
Thank you. I really enjoyed it. Great questions from you and great questions from your audience.
Yeah, very thoughtful and eloquent. So thank you very much. A virtual round of applause, and have a good afternoon to you, Matthew, and everybody else. Thank you.